All right. Well, let's go ahead and get started. We've got a pretty full agenda today, and I want to be respectful of everyone's time. So welcome everyone to Aurora Health Alliance's Addressing Youth Suicide webinar series, part 1. Thank you so much for joining us today and to talk about this very important topic. Since we'll have a larger group here, if you'd like to, we won't do individual introductions, but please feel free to use the chat function to introduce yourself with your name, organization, and any contact information you'd like to share. Please also remember to keep yourself muted unless you're speaking, or try and minimize the interruptions today if we can. This webinar series is also being recorded, so it will be available to you and to your networks after it is over. And in terms of asking questions, once we're done with the speakers, feel free to use the chat function. You can raise your hand. You can also, if you want to ask a question anonymously, you can send a question to me specifically, and then I'll ask it for you. And I think that we have all of our speakers present, so thank you so much. And just to our speakers, if you're also willing to share your contact information in the chat, that would be helpful, especially if we don't get to all of the questions today. And also to our speakers, we have a timekeeper. We'll let you know in the chat when you've got a 2-minute warning, just to keep us on track. And again, thank you all so much for being here. And with that, I'm going to turn it over to Coleman.
Great, thanks, Joe. Hello, everyone. Welcome. We're really happy to have you today. I have the pleasure of introducing a colleague, Dr. Lena Heilmann from Colorado Department of Public Health and Environment. She is the Suicide Prevention Strategies Manager within the Office of Suicide Prevention. We're really happy to have you kick us off this morning, Lena. Thank you so much.
Wonderful, good morning. And I'm going to go ahead, I know we're watching time here. So, hi everyone, my name is Lena Heilmann. My pronouns are she, her, hers. I'm with the Colorado Office of Suicide Prevention, and we are housed in the Department of Public Health and Environment. I coordinate most of our youth and young adult activities. And what brings me into this work is I'm a suicide loss survivor. I lost my sister Danielle to suicide in 2012. So today I'm going to be providing just a little bit of data overview. And the idea here is not to provide comprehensive data. There's not enough time for that, but to give you some touch points so that you can look at the data a little bit more closely on your own and to kind of navigate through some of the ways that we can look at data specific to youth and to suicide prevention, etc. Before I begin, I really want to emphasize a few main points. One is that we really care about the preventability of suicide. There's a lot that we can do to make suicide as preventable as possible. And so there are a lot of things that we can do together to make suicide the least likely outcome for someone struggling with suicidal despair. Also, when we talk about suicide, we often focus on suicide fatalities. And of course, as a suicide loss survivor, I know very well the devastating impact of a suicide loss on the individual, on the family, on the community, and so on. We also want to be sure that we're empowering stories of hope and resilience. Most people will recover from suicidal thoughts and behaviors. So part of our prevention work has to be to understand what is helping people survive and how can we support what's already in place and expand it so that suicide can be as preventable as possible. Also, suicide and suicide prevention are community issues. There's no one agency or department or unit that is solely responsible for suicide prevention. So schools, family systems, after school programs, health systems, and so on for youth suicides in specific. So we don't ever want to just focus on one system when it comes to making suicide as preventable as possible. Also, we know that prevention, intervention, and postvention are all important in a comprehensive suicide prevention approach. And finally, suicide prevention cannot just be about keeping people alive. We have to work together to create communities worth living in and to support people to have lives worth living. I'm going to jump to the data. And I'm going to go through this really quickly. And this is always a little bit of a personal tension for me because going through data quickly sometimes doesn't feel great to me because we're representing real people's lives. And I imagine everyone on this call has been impacted by suicide, whether it's our own thoughts of suicide, surviving our own suicide attempts, supporting family members and loved ones through suicidal despair, and possibly also being suicide loss survivors. So I just want to hold a little bit of space to acknowledge our loved ones are often encapsulated in this data. And although I'm going to go through the data in this higher level because that's important for our suicide prevention efforts, I deeply honor the lives that this data represents, and I hope that you do too. This quotation, I think, is always a nice way to start this section, which is that statistics are merely aggregations of numbers with the tears by the way. So I want to acknowledge the tears that we've had and the love that we have for the folks that these numbers represent. So this slide is filled with a little bit of information to show the bigger picture about suicide. So every year, about 10 million adults seriously think about killing themselves, and about 3 million make a plan to die by suicide, and about 1.3 million make a suicide attempt. And I have to update this number because we have better numbers, but about 48,000 people each year die by suicide. So there are two different ways to look at this picture. One is that if we only look at suicide fatalities, we're missing a broad range of experiences that also deserve to be honored and respected and included in our suicide prevention efforts. It also means that if we're only looking at our fatality data, we are not seeing the full impact of suicide on our communities. The other way to look at this is that the majority of people who feel suicidal do not go on to attempt or die by suicide. So part of what we need to do is also hear from people who have survived suicidal despair and empower that experience so we can encourage people to know if I'm feeling suicidal, there are many other people who have also felt suicidal and not gone on to attempt or die by suicide. That's a message of hope and resilience that I hope we can all join together in sharing. And the screenshots here are little, and so I tried to blow up a few moving forward. But we have on our Office of Suicide Prevention website, which is COOSP.org, a data tool. So all of our suicide fatality data is on this interactive Tableau dashboard. And so this is just a screenshot of kind of the data. So you can see there's a map of Colorado, there's counties to click on. On the right-hand side, there are age categories to click on: sex, race, ethnicity, marital status, veteran status, and Medicaid enrollment. And then at the top, there are a few different tabs, and I'll go through some of those. So this is really an opportunity for you all, personally or professionally, if you're interested in looking at fatality data, to use our data dashboard to meet your needs. So I'm going to first start with a little bit of Colorado data. So this data is 2012 through 2016. Trends look very similar. We can update the slide, but it's going to look pretty much unchanged. And what we have are the columns are age ranges. So the first column is 0 to 14 years, 15 to 24, 25 to 34, and so on. In orange is male and blue is female. We don't have great fatality data outside of a sex binary. Hopefully we'll get to that in the upcoming years. But I always think this is really important to emphasize because we see that people die by suicide across the lifespan. And we see that the highest rates for suicide are among men or males ages 25 through 64. And we don't want to ever forget our older adults, 75 and up, who also die by suicide. And I point this out always for two reasons on youth suicide prevention efforts. One is just to acknowledge the impact of suicide fatalities on our community across the lifespan. And number two is really to go back to that idea of creating lives worth living. So if we just keep a young person alive until 18 and assume that once someone is 18, they're not going to die by suicide because suicide is a young person's problem, which is something I've heard before. I want this slide to really acknowledge that we want to help young people not only come out of suicidal despair in their teens, but to set them up for a lifelong journey of being connected, supported, and having all the protective factors in place, because suicide risk doesn't necessarily in aggregate go away across the lifespan. And if put a little bit differently, we see that 70% of suicide fatalities in Colorado are adults 25 to 64. The next largest bucket of deaths or categories or bundles is older adults 65 and up, and then young adults 19 through 24. And then youth ages 0 to 18 make up about 6% of our suicide fatalities. That's just showing where our fatalities kind of aggregate in our fatality data here in Colorado. We also have a slide here for race and ethnicity. What's not on this slide are confidence intervals. And so I think the takeaway from this slide is that people of all races and ethnicities can feel suicidal, can attempt suicide, and die by suicide. So we have to be inclusive and intentional in our efforts. I also want to point out another data source, which is the Healthy Kids Colorado survey. So this is every other year. There was an abbreviated survey in 2020, but generally the last comprehensive survey was in 2019. And that's another kind of Tableau interactive feature. So you can sort through regions and look at different indicators related to substance use, to different aspects of someone's environment or living experience, and some suicide specific indicators. So I think this slide really points out some of the disparities that are impacting Black, Indigenous, and youth of color in Colorado. So we see that percentages of students who reported in the past 12 months making at least one suicide attempt is highest among our Native Hawaiian or other Pacific Islander non-Hispanic youth, and our American Indian or Alaska Native non-Hispanic youth. We see a very similar disparity for feeling sad or hopeless. And again, the percent of youth who reported having at least one trusted adult to go to for serious problems was also the lowest numbers among Black, Indigenous, and youth of color compared to white non-Hispanic youth. So again, even if our fatality data with our confidence intervals is showing kind of a broad picture, we see specific disparities specifically impacting Black, Indigenous, and youth of color. So we want to be really comprehensive and intentional about our efforts there. I pulled a little bit of data specific for Adams, Arapahoe, and Douglas counties. And so one caveat is that when we look at fatality data, the impact of one person's death by suicide is, of course, incredibly impossible to quantify. From a data perspective, looking at 1 year, one age range, and one county at a time is really difficult to do because we might have one suicide fatality in an age range in a county in 1 year and two the next year. And we could say that that's double the suicide fatalities. And although that's true, the next year there might be one or two deaths again. So it's the smaller we make our categories, the bigger that data ranges. So sometimes I try to combine a few different counties to be able to pull out some trends. So here's just kind of a screenshot what that looks like. I click on the specific counties that I want and it auto-populates. So total suicide deaths in these three counties, 2019 through 2020, no, this is all 2019, is 290 suicide fatalities. Zoomed in a little bit on this part, and so we see the year breakdown. So for 10 to 14 years of age, we see 3 suicide deaths, and 15 to 19 years, we see 26 suicide deaths for 2019. Compared it to 2020, so again, the 3 counties, and I selected on the toolbar the 2020 age range or the 2020 year range, and there were 281 suicide fatalities, 7 in that 10 to 14 age range, and 27 and 15 through 19. So it's just a way to look at some of the trends and do some of those deeper dives. And again, I encourage you to go in and look at the numbers that you need to inform your efforts. There's a lot of different ways we can look at this data and to kind of get some bigger pictures and to look at some of those trends. It's also important, so those were counts. And so when we look at counts in general in Colorado, we see counts going up year to year. And part of that is because Colorado is a really quickly growing state. And so it's also important to look at our rates. Always a big picture to kind of compare all these different components always think each piece of data is like one part of a puzzle. So we can't just look at one part of the puzzle and understand the full picture. All the pieces have to fit together to make out what's really happening. So I've compared 2019 and 2020 in those 3 counties, and we see that the rate per 100,000 deaths, which is how we count data in public health, was 18.7 in 2019 and 17.9 in 2020. So it looks like the rate went down a little bit. But there's another caveat, which is that we have to look at those confidence intervals. There's the confidence interval, the lower and the upper. So if the confidence intervals overlap, and if we can think of like 16.5 to 20.8 and 15.8 to 20.1, those are overlapping. Those numbers have numbers in common. That means that the difference is not statistically significant. So we would say basically that that rate is holding steady from a statistically significant point of view. So I did the same for the age ranges 10 through 19. And it looks there like the suicide rate went up a little bit. But again, we have really wide confidence intervals because those numbers are really low. So we would again say the rate of suicide fatalities did not increase in a statistically significant way. So that's what that means when you hear some of those terms and what that data looks like and the way some of those pieces fit together. I know I just have about a minute left, so I really want to emphasize that one of the things that we know is that suicide is not specific to a mental health condition. There are a lot of reasons people die by suicide, and it's often or nearly always a combination of factors that contribute to someone feeling suicidal. So in 2018, the Centers for Disease Control released a report that showed that about half of people who died by suicide did not have a known mental health condition at the time of their death. So that means that suicide prevention efforts have to look at relationship issues, issues with systems, whether that's school or the workplace or faith communities. We see that relationship problems are really highly indicated as one of the contributing factors. A crisis in the past or upcoming 2 weeks, a physical health problem. So again, to make suicide as preventable as possible, we can't focus solely on mental health, although mental health can be one piece of the puzzle. We see a lot of other issues that are also contributing to suicidal despair. At the Office of Suicide Prevention, we've pulled out some of these focus populations. You probably can look at this really quickly and say, that looks like everyone. And that's true. We really want to serve everyone in Colorado. We just know that the strategies for older adults look different than the strategies for youth. But again, we know that suicide has an impact across the lifespan. So we support everyone across the lifespan. I can share these slides. This one just shows an array of the different programs that we have out of the Office of Suicide Prevention. So if you're interested in knowing more about which work and efforts we fund and lead and coordinate, there's a fairly comprehensive list here. And then, of course, if you have any questions, feel welcome to contact me at any time. My email is here. I can answer questions in the chat or however works best after everyone else's presentation. And thank you so very much. I really appreciate it.
Lena, thank you so much for that information. I want to introduce Emma Goforth with Tri-County Health Department. And Emma, you should be able to share your screen if you'd like to.
All right, great. Well, thank you so much for having me here today. And Lena, thank you very much for really setting a strong foundation. I think that I would echo much of what you shared in terms of the context of data. And I also think that the complexity of issues is very important. And so as we look at lots of different factors, there's many different ways to look at them. So I have just a few additional lenses of data to share. And then I'll talk a little bit about some of the efforts that Tri-County Health Department is involved in for our future. But I wanted to share this data. So this comes from the Healthy Kids Colorado survey. So these are surveys that are given to students in schools around the state, and is a really very rich data source for us to hear from youth and adolescents about their experiences. And so as we certainly want to track and understand fatalities and interactions with the healthcare system, hearing from students about their perceptions and attitudes and behaviors are very helpful as well. So as you can see here, about a third of high school students, and this is within the Tri-County region, so Adams, Arapahoe, and Douglas counties, report feelings of depression impacting their usual activities. We also know from the survey 15 to 18% reported seriously considering suicide. 10.4 to 13.3 made a plan for attempting suicide, and 5 to 11% reported that they attempted suicide in the past 12 months. This is 2019 data, and is the most current that we have from the survey source. Lena, we look at these dashboards, we use them often. I won't spend time on that. But we do work with our data specialists at Tri-County to help visualize the data in some ways. And so this is using some of that data through a mapping system to show us where we have community level concentrations or regionality in terms of trends. And so this is deaths, excuse me, I need to move my little toolbar, due to suicide across all ages in 2019. We certainly look at these counts. One death is too many, but I'm trying to understand trends in terms of numbers is very useful for us. And these come from vital statistics sources. Tri-County is very interested also in drug overdose, and that's been an area of priority for us. And I think that it's of interest to look at the full array of factors that may be contributing. And so this is information about substance overdose use, and we see some increasing trends in 2020, especially related to opioids, fentanyl, but also methamphetamine and cocaine. And then when we break it out regionally, we have some changes happening there too. Here's a similar map and looking at the deaths due to overdose in the Tri-County area. And now I'm going to shift a little bit, and I will probably not do anywhere near as well as our actual syndromic surveillance folks in describing this data, but this is a data source that really shares information regarding trends in emergency department visits. There are a number of hospitals that participate in this, and we are able to really look at visits across geography, by residency of patients in the hospitals. You can see that when we show the Aurora data that the zip codes of residents that were included. And so today we're going to look at youth data. We have similar data for adults as well. And so what we'll be looking at are emergency department visits related to suicidal ideation, suicide attempt, as well as drug overdose. And so this is a graph that spans from May 2019 up to July 2021. And you'll note that the purple line speaks to the suicidal ideation, green suicide attempt, and gray all drug overdose. And what we see is that ED visits related to suicidal ideation are higher than attempts in drug overdose. And the higher counts were identified for both youth and adults. We also see that the suicide attempts the overdose data is slightly higher or similar to the suicide attempt data. And then we also see that the ED visits in suicidal ideation peaked at a certain time. So right now we're looking at Adams County. I'll go to Arapahoe County, so very similar pattern. And then here's Aurora. And so again, looking at the trends, we see these fairly significant spikes in count at certain periods of time. It is important to note that Children's Hospital data only began to be represented here in October of 2020. So that may impact the data here. But an interesting way for us to really be able to view sort of that real-time data source. I'm going to change gears a little bit and just speak to some of the community assessment work that we've been doing over the last year and a half or so. And this is a summary of a very detailed report that we had as a result of lots of key informant interviews. Probably a lot of people on this this webinar today were talked with, and what we wanted to better understand is the mental health system elements, and seeing that we have a number of strengths, but also a number of areas. And a couple of the things that I'll just pull out here, really have to do with stigma, a growing awareness of these issues, but also lots of challenges with fit and choice and options in terms of services. There's a lot we could say about this slide, but I'll move forward. From some of that assessment, Tri-County really pulled together a number of partners to develop these frameworks. So we have one for mental health, and then one more specific to suicide prevention that kind of tucks underneath that umbrella of the mental health framework. And these really help to give us some direction around the work that we do across mental health and suicide prevention in partnership with you all and others in our community. And so I won't go through this in detail, but just wanted to show you a graphic here that speaks to the many strategies that may come into play across the continuum. Lena mentioned this, sort of the idea that there's areas of influence from health and wellness promotion to prevention to clinical and support services, and then in recovery and reclamation. We have lots of principles that guide this work, lots of ways that we do this work that are common, including looking at our data, many values that inform how we do our work. And then this outer layer is really sort of our overarching outcomes that speak to this quality piece, so that we're really hoping that through this work that our outcomes are that people have hope for their future, and that we have belonging in our community, that there is purpose and meaning in individuals in our communities. For the suicide prevention continuum, it's very similar to the mental health piece, although you'll notice that the bright green second to inner ring says postvention and recovery, and really that's very much tailored to the idea of postvention, both with individuals and in communities. And so we've outlined what we know in terms of the evidence-based and research-informed strategies to consider, and I'll just go through those very quickly. Also just wanted to give a shout out to the overdose prevention framework as well. We see areas of overlap and complement with the work that we have under that mental health and suicide prevention framework. And then lastly, just wanted to share very briefly that we are currently promoting a campaign, so recognizing that stigma reduction and promotion of services and resources are an important strategy that is targeted towards youth. This is an awareness campaign that was really developed at the state level and connects people to the Colorado Crisis Services text line. We've been able to utilize some funds to invest in this campaign starting in August and through to October. This is a great campaign that was really developed by youth for youth. And the idea is really that below the surface, many youth deal with feelings of isolation, stress, anxiety, a variety of issues factor into that. And so the idea is to help young adults recognize that there are these feelings happening under the surface, that they're not alone, and that there is help available. So the campaign looks like this. We can just blow through some of these very quickly. There's social media, there's videos, there's a variety of other campaign collateral available. All are tagged with the resource back to the Colorado Crisis Services. There's some fantastic videos. We don't have time today to look at these, but I would certainly encourage folks to spend some time on the website, understanding and hearing from youth. And then just a quick flash on how it actually works if someone is to text the crisis services here. So we are happy to talk more about some of these strategies. We also have some of the other efforts that Lena flashed on the screen in terms of the gun shop project and other strategies. This was just one last slide to just perhaps get this group thinking a little bit about how we are in a period of reassessment and understanding the landscape related to mental health and suicidality, and that we're really seeing some changes in care needs, as well as the availability of telemedicine. And this idea of really thinking about the social determinants of health is really crucial. So an understanding that the disparities or the challenges that existed before COVID have widened in many cases, and that those determinants of health certainly play into the determinants of mental health and or risk for suicide. So here's my contact information. Happy to chat offline, but very grateful to be able to be part of this conversation.
Wonderful. Thank you so much, Emma. We do have a couple of questions that came in. So while I kind of take a moment to breathe and take in everything that Lena and Emma shared with us, I want to share a couple of questions. One of them is, I think for Emma, can you speak more to how Tri-County Health is implementing the suicide framework?
Yes, so this is really a brand new product for us. And so we are, part of our interest is engaging with our community partners and others to address some of the strategies there. So one of the low-hanging fruit strategies is the below the surface campaign, and really being able to put those messages into social and digital media feeds, an early strategy. But we have lots of work to do with our schools, for example, and really working with them around understanding this syndromic surveillance data and amplifying those messages and engaging with youth as ambassadors and messengers around the campaign. So those are areas that we are laying the foundation for. I will say that our attention continues to be very strongly focused on COVID response, and it's an interesting time right now. We have a lot going on around varying understandings and beliefs, masks in schools, but mental health and the suicide prevention concern comes up often in those conversations. And so we're navigating that, and I'm really trying to best understand how we can support our communities as we struggle with those questions. We do have the Gun Shop Project in place and are looking to expand that. This is a program where individuals can go and work with gun retailers around safety practices. It's a fantastic program. And beyond that, more to come. We'd love to chat with you all about ideas for implementing that framework.
Thanks, Emma. Thank you very much for your information. Really appreciate it. Okay, well, let's move on to our next speaker, Heilmann Coleman.
Great, thank you very much, Joe. Well, I'd like to build off of what has been presented today by both Lena and Emma. I'm Heilmann Coleman with Partners for Children's Mental Health. And I'm looking at my second screen, so just know that when I'm looking away over here. Most of you, I'm sure, are familiar that Children's Hospital declared at the end of May a pediatric state of emergency. And as you've seen by some of the data presented to you today, volumes are increasing in our emergency room departments and inpatient units. The severity is continuing to increase, as well as the overall need. And that's why we're all here today to discuss. Children's Hospital over the last 2 years has seen a 90% increase in the demand for behavioral health treatment for youth. We know that the continuum of care is not as robust as it needs to be in order to support our youth and family in Colorado's. Community and home and community-based services also need to be more robust, and just an overall lack of coordination, as we've seen in some of the earlier slides today as well. I'd be remiss if we didn't call out that this crisis isn't due to a lack of expertise in Colorado or dedication or the effort to reform and improve. Colorado actually is very motivated to reform and improve and has had a lot of different initiatives, many of which many of you are leading today on this webinar. The problem continues to be the lack of coordination across the system and making it really easy for the youth and families that we serve. So that's why Partners for Children's Mental Health was created. We were established in 2017. We are serving as a center of excellence model that is supported by both Children's Hospital Colorado as well as the Department of Psychiatry out of CU Medicine. Our goal is to help with be a cross-system resource training, evaluation and implementation hub, as well as workforce development. And the goals are very broad, including helping to increase capacity, access, and the quality of services that both youth and families are receiving. We can't do this alone. Again, we just talked about that coordination and partnership is imperative. And so we are working with many different partners, including many of you on the phone, to identify, scale, and really work towards sustainability of best practices that again will eventually and start to save lives and get treatment to the youth and families. We operate under a 5-core function structure at PCMH. And so at the top of this graphic, you'll see the outreach, engagement, and collaboration is again imperative. We know that this is a partnership. This is going to take all hands on deck. When you go directly under workforce development, ensuring that the workforce is adequate, is representative of the families and youth that we serve, is diverse, and is accessible, and is skilled and trained is something that's absolutely needs to continue to be a focus for us to improve the overall system. We have a research and evaluation component to our work. And so as we're implementing or offering evidence-based, evidence-informed trainings, we're able to evaluate those in-house. And then a policy and finance arm to what we do. So advocacy, legislative efforts, bringing together experts and people like yourselves that are doing this work day in and day out and boots on the ground to really help informing how legislation is written. And then finally, implementation support. Both our research team as well as our training team offers implementation support to two of our main partners being schools and primary care. So Partners for Children's Mental Health, or PCMH as well, we really are focused on a statewide approach to change. So at the statewide level, through engagement and in collaboration, we're striving to create and build lasting relationships that will help reduce the fragmentation and the duplication across the system. Through policy, finance, and advocacy, we continue to gather and share critical data that can inform legislative efforts. So again, making sure that we're informed by CDPHE's data, Tri-County, again, being here in our local community as well, making sure that we really understand the nuances of each different locality. And then through workforce development, our research and evaluation and implementation support, we are creating consistency and standardization of care models that again will reduce the burden on both providers and the workforce, as well as our families that are trying to navigate such a complex system. So let's, oh, I skipped a slide, sorry about that. So let's go back. We talked a little bit about the statewide approach. In local communities throughout Colorado, we are working to increase the availability of evidence-informed practices. For example, we have a program called PracticeWise that we're implementing with behavioral health clinicians that is around evidence-informed treatment for youth. We are improving mental health equity, or looking to partner to continue to help improve mental health equity, and particularly as was pointed out earlier in the slides, in our rural and low resourced areas. And then implementing suicide prevention initiatives in both schools and primary care is a main focus for us. As you all are well aware, youth and kids are showing up in primary care and family medicine, as well as schools, more than any other venues. And so really partnering with the professionals and the workforce that are serving our kids on a daily basis. So let's change things together. I think that's why we have nearly 40 people on this call today to really think about what a collaborative approach is. And you've heard both Lena and Emma talk about that it is that coordinated and collaborative approach in order to see true systematic change and transformation. So the last slide I wanted to show today is just to highlight the 6 key initiatives that PCMH is currently working on in 2021. And so as I mentioned already, we have an initiative with schools where we're providing free training and technical assistance to help schools effectively identify, intervene, and support students that may be at risk for suicide. We have a steering committee that helps guide some of those efforts. We also, again, are working with primary care and family medicine to help train our providers and docs on how to implement suicide screening and assessment tools that will increase identification of youth who may be experiencing suicidal ideation. That workforce development piece, we're pleased to continue to be able to offer free learning opportunities that are online with a live trainer, or on demand, do them at your own time and pace. And we're offering gatekeeper trainings that include youth mental health first aid, adult mental health first aid, the QPR or question, persuade, and refer training, as well as ASSIST, which is applied suicide and intervention skills training. And again, we're pleased to still be able to offer those trainings free of cost. I mentioned earlier about our PracticeWise initiative focused in rural communities. And this initiative is all around the training of behavioral health clinicians to give evidence-informed treatment to the youth and kids that they're serving. Policy and advocacy, we continue to work with our legislators. Right now, as many of you are aware, we've got a bunch of ARPA funds coming to the state. And so really gathering key stakeholder feedback and input and working to inform how that particular money could potentially be spent relative to youth and families in our state and in our area. And then the last thing I wanted to mention is we're just wrapping up a youth engagement project at PCMH. And this is the first time that we were able to bring on 2 youth consultants, where over 8 weeks, we've been working very intensively to help build their knowledge and confidence for them to be able to participate in systems change work, and then help us really think about co-creating a sustainable approach in an authentic way for how youth engage with other youth. And so we're really hoping to learn a lot from this last 8 weeks, and our youth are actually going to be presenting what they've learned and their recommendations to our team at the end of this week. So I just want to say thank you for allowing us to share a little bit about what PCMH is doing here within our community in Aurora, in our counties, and then from the statewide landscape as well. And I appreciate everybody's time today.
Shailyn, thank you so much. We'll have Rick go next. While we're waiting, why don't I just put a question out that came through for Lena, Emma, Shailyn, and Rick too. And I think it's really kind of one question that really stood out to me is, how do we normalize this conversation with our youth, especially when things seem normal or in the absence of issues? How do we normalize this conversation? And that's for any of you.
I mean, there's a broad question. There's probably different strategies depending on the relationships and the individuals. But I think one thing adults in general can do is model those conversations and show their own thought processes and share our own struggles, our own, if we've had thoughts of suicide, if we've survived suicide attempts, to talk about those openly, or to talk about emotions or conflicts at work, and really model what we go through in our lives to normalize that, and to engage in conversations with young people around a variety of topics, and always to validate and affirm young people's emotions and not try to problem solve for them, but to help a young person think through different options they have. So one thing we see with suicidal despair specifically, and the move from suicidal despair to suicide attempt, is people across the lifespan feeling like there are no other options, like all the other options are gone. And so I think the more that we can practice for ourselves and the young people in our lives, what it looks like to sit in a really complicated problem, to feel trapped, but to think about various options to problem solve, can help someone when they start to feel really kind of caught in that despair, to be able to identify supports that they have, to know how to get through a day, to know how to navigate conflict, and to really build some of those skills.
Well, good afternoon, everybody. I'm Rick Padilla. I work for the Denver Department of Public Health and Environment. Suicide prevention is my focus. But I'm Jack's dad, and that's what I want to, all the great work that my friends Lena, Emma, and Shailyn talked about. I want to put a face to those statistics. But to understand that, you need to understand who my son Jack was and is. And I'm going to share a short video with you. And if I get a little emotional, I'm not going to apologize. That's just the way it is. So, but let me share with you who Jack was. Well, And again, I don't know how to take this video down. So I'll just talk. When Jack passed, I started to do a lot of advocacy before I came back to the city. But what the job that was created for me at the city is not really a job, it's a purpose for me. And a part of Jack's story is there was some bullying behind it. So I decided to pursue some legislative action. And the legislature and Governor Polis just signed it. It's called Jack and Kate's Law, a bullying prevention and education in schools. And we'll be moving forward as the Colorado Department of Education looks at the current law, which can be is to be revised every 3 years, and that's in 2022. But I think it's just my point in showing that video is really understanding behind the statistics. Normal family, suicide impacts not only a family, but an entire community, as it has in our case. But from that, I've gone back to the city and we're involved in a number of initiatives, including a youth summit this fall that some of my friends here in the video I've spoke with and will join us. It's called We Got This. It was the name, about 12 of Jack's friends came to our house after he died. And they said, we need to do something, Mr. Padilla. So I said, put your phones away and participate. And they came up with 11 items they wanted to accomplish. Jack's Law, Jack and Kate's Law was number 10. Number 11 is the We Got This Youth Summit. And I've asked Joe to kind of just send out a fact sheet for those of you that would like to be involved. Our friends, many friends on this phone are actively participating, or their respective institutions are participating in doing this youth summit on October 25th at DU. And it's by youth, for youth. We've worked with many of the hospitals that are represented here and their clinicians in creating abstracts that youth are working on with the creative community, including some national recording artists, and we'll be doing as well as some traditional breakout sessions. But it's really focused on identifying, giving a platform to youth and giving them a voice. We're going to do a video, we're going to write a narrative, we're going to, with graphics, that'll really, we hope the outcomes of the summit, we're going to document whatever the youth want to do over the next 3 to 4 years. And so We Got This summit, and I'm happy to talk with any of you about that a bit more. We're also going to do at the city an anti-stigma campaign focused on substance misuse and suicide prevention. And the last thing, that major project we're working on, the city of Denver is going to do behavioral health assessment of the residents of the city of Denver that want to participate. We need to get a pulse on what's happening in our community. Our kids going back to school is not going to be just going back to school. There's lots of issues that I think that the clinicians certainly on this phone can talk to much better than I. But again, I just wanted to share with you a family behind the statistics. Thanks, Joe.
Thank you, Rick. Thank you for sharing Jack with us. Really appreciate it and the work you do. You know, we are still wanting discussions around how we can all work together in terms of talking about this issue, normalizing it. So if anyone has any thoughts around that, please feel free to speak or put your thoughts in the chat.
Joe, I'll share now that I've composed myself a little bit. But you know, it's really, really important the work that all of us are doing. This we look at hospitalization data in terms of ER visits and also the lack of bed space and trying to get kids into that. I think the work that we're all doing, I couldn't be happier that this issue is getting elevated, because you know, we got to look at the mental health of our kids, and it's really important work that each and every one of you are doing. And I think to the point that was made earlier by Lynn and Lena and Emma, is that we have to collectively look at this. This is a community problem. It's not a problem of our schools. It's not a problem of local government. It's a community problem. We as a community need to address this. And I'm really grateful to you folks having me and all of us today, because I know these folks very well. We've gotten to know one another over the last couple of years around this issue. So I think that we have a real opportunity to make some substantive changes as we not only just do presentations or summits, we collectively think of strategies to address this escalating problem in our community and across the country.
I just want to say thank you again to our speakers, Lena, Emma, Rick, and Shylin. Thank you so much for your time and for the discussion. If you'd like to share your slides with us, we'd appreciate it, and we'll get those out. And hopefully you can all join us at our second part, which is September 21st, noon. It's via Zoom as well. And thank you all again so much for your time.